Now, moving on to the 1980s, 1990s, and early 21st century, let's talk about a book that was very influential as far as the general practice family medicine approach is concerned in the Western Hemisphere, mainly the United States and Canada, which is where most of the consultants coming from, especially Asia, went to during the 1970s and 1980s to figure out what the deal is and what family medicine is. And this is one of the most popular books during that time. Later books were entitled Textbook of Family Medicine, but the original would be the one that came out in 1981. So it's an introduction to family medicine. Now, the difference between the one that came out in 1981 and the one that came out almost a decade later, clinical stuff and chapters were continuously being added. And of course, the reason was very clear. If you look at what family medicine was turning into late 1980s and 1990s, that's the rise of managed care and HMOs and insurance companies, and then so doctors and the industry decided that family medicine doctors, since they became more well equipped with additional training for about 2 to 3 years, well, actually they weren't interested in the psychosocial family community integration part. They're actually interested in the additional training and the clinical stuff. They decided, well, they're the cheapest, most efficient way of doing gatekeeping. The idea is you're the gatekeeper, and they see the patients, they try to do as much as they can, and the things that they cannot do are the only ones to get through, right? So money saved is money earned, right? And that's also the time when family medicine felt a surge in income. They became important as far as the healthcare, medical care industry is concerned, so they started to get paid more, right? And that's the reason why we're just doing a whole bunch of clinical stuff. It just kept on going, and that's the reason why right now we're just doing a whole bunch of clinical stuff like blood pressure, cholesterol, diabetes, the basic ones, cough and cold and things like that. And of course the industry says, if these people get all the way to the allergy clinic or the ENT or the cardiologist, will be paying a whole bunch of people doing specific stuff, why not just give it to the primary care generalist or family medicine doctor who'll do all of them? We can pay them this much and it still will come out cheaper, right? So that's the idea of the gatekeeper. So you have the 1989 version, and then you have succeeding versions. So this very popular book sort of gives you an idea what generalist practice is and what family medicine is. Family med is still considered general practice as far as much of Europe and United Kingdom is concerned, and or family medicine or family and community medicine. Some people add community medicine into the mix during the 1980s and 1990s. Afterwards, the community medicine people, of course, realized or saw that the community part is becoming smaller and smaller, and there's no community and gatekeeping. So that's the reason why in some places they have problems right now. The community medicine people feel like, you left out the other stuff. You're happily getting paid for the stuff that's not even relevant to your other half. You even forgot your other half. You forgot the community, and then you're beginning to forget your own psychosocial stuff. It's just an add-on. You teach it, you talk about it, you workshop it, but in actual practice, you have a bunch of 20 to 50 people for the day, and all you're doing is this, right? So anyway, so the most important idea, even in the first textbook or the first book, would be this principles of family practice. So what family physicians are. If you look at the other books, it starts out with what the discipline or the field of family medicine is. Now, this one starts out different. It starts out what the family physician should be. Now, of course, those two things should be related because, the field of study should have an application, because being a doctor, that's not a theoretical field. That's an applied field, right? You're taking care of people. Now, some of you might go into research, but most of you, or the bulk of your field, should be taking care of people, right? So it defines the family physician. The focus now on what you should be rather than what your field is, right? And the idea is what you should be will define what your field of study and research is. And then Dr. Mcwhinney will describe 10 or so ideas about a family physician. So he will describe what a family physician is. Now, instead of just going through the list of what he said, he actually enumerated them with numbers. It's easier to understand. You can actually come up with all these things without reading them if you know what he's trying to tell you. Okay. And what he's trying to tell you is based on his life experience. So, what is his life experience? He wanted to be a doctor right from the start. He saw the general practitioners. Now, general practitioners during the 1930s, 1940s, 1950s, you go into med school, you graduate, and then you're a general practitioner. And then he's looking at his father and the friends of his father who are doctors, work very long hours, and he has a clinic, a very busy general practitioner. During that time, that was like 1940s, 1950s, doctors are not driving around with fancy cars and talking about stocks instead of talking about patients. That's later on, after they got money poured in and everyone started getting corrupted, the boasting about the latest cars and skydiving and the fanciest hotel conferences and the trips to Europe and the bags, and that's after it got corrupted. But during his time, he saw his father. He's working many long hours. He goes to the houses because they live in the community, right? So he goes to the houses of his patients, especially those who are very sick, those who are dying. He stays there. There's not much he can do because it's the 1940s. But he stays there because a doctor is supposed to take care for the patient. Cure is nice, but if you cannot cure, you still have to care, right? That's the idea. And he wanted that. And then what happened? Then you have the world wars, right? And then he served with the Army Medical Corps during the Second World War. So this one also contributed to his idea of what it means to take care of people. You're there, you see a lot of injury, trauma, suffering, a lot of emotions. And what is it? You see the humanity, right? You don't just see someone with a missing arm. You don't see someone who's bleeding out. You see a person with a family left behind who's worried, who's scared, and you're trying to help this person with the bleeding, actually talking to you, telling you his concerns. So you're seeing the person with the missing arm, or you see the person who's bleeding out to death. So that's his experience. He went back and worked in his father's clinic. During the early part of family medicine and even general medicine, the people who go into general practice are the ones who like that thing. So they didn't go into it because they think it's financially lucrative to do so. They like the experience of taking care of people in the same community, talking to them and seeing the mom, and then suddenly brings in her dad, who's the grandfather of this kid. That's what they want to do. And that's the reason why family medicine, the leveled up version of general practice, when they attempted to retool or make the general practitioner better adapted to the increasing amount of medical knowledge, that's the reason why it remained strongly psychosocial. So it held on to that idea of family, person, client-centered, psychosocial, because that's the experience of being a family doctor during the 1930s, 1940s, and the 1950s, right? Now, of course, that's pretty much gone. I mean, they made a really good attempt. The founders made a good attempt. Now, of course, once it expands and then money gets poured in, and then suddenly everybody's having a swell time with increased income being gatekeepers, then no matter how nice the idea was when they got started, the pioneers can only go so far. And then you'll see later on, most of them were writing about going back to their roots, like paying attention to the healing instead of everything else that they've been doing later on, right? But anyway, we're not doing 20th century or 21st century yet. That comes later on. Well, anyway, to finish up his story, before we go to the principles or what a family practitioner is, he left his father's practice. Why? He left his father's practice after almost a decade and a half of working there, and he really enjoyed it. He liked it. That's the reason why he wanted to be a doctor. Why did he leave it? Because the University of Western Ontario in Canada asked him or begged him to become the first chair of their Department of Family Medicine. During this time, like mid-60s, 1960s, the general practitioners or the ones who are very concerned about their field are feeling or seeing the problem of modern medicine. And they're seeing the decline of general practice. Nobody wants to go into general practice. The specialists coming out of the modern medical centers think they're about to go extinct. And what we'll have is a group of very smart, subspecialized clinicians. And whatever your problem is, you go to that very smart, subspecialized clinician who has a huge amount of knowledge and great skill to take care of you. So the disease will determine the group of specialists who will take care of you. Of course, he knows that's not the way it should go. For one thing, the person is not in the disease, right? So if you do that, then you have a person with 5 diseases going to specialists who are only concerned about the particular disease he should take care of. So what happens? Well, for one thing, the person goes away. The psychosocial part goes away. The family also goes away. If you don't have any person, the family also goes away. Even the community is gone, right? So the specialist is usually not even in the community. And as far as their research and studies and clinical trials are concerned, it doesn't really matter where you came from. And it doesn't really matter who and what your family is. It doesn't even matter much how you're reacting to your disease, right? Your illness experience. And so these things are happening, and the group of well-meaning, very academically inclined, scholarly general practitioners, including Dr. Mcwhinney, were very concerned. So he had to sacrifice the thing he loved doing the most and accept the position in Canada. He left the country. He's from the United Kingdom. He had to pack up and leave with his family, go to Canada to try to save the situation, right? So that's what actually happened. So that's a very huge sacrifice as far as he's concerned, but it's a sacrifice that needs to be taken, right? So from a life that's fairly peaceful and great for him, he likes what he's doing, and then he goes on to do this thing for the first time and face all the difficulties and problems trying to fix medicine and trying to show everyone a better way of doing it. Of course, they tried really hard, but in the end, well, we won't go into that right now. Now, if you think that way, then everything will be simple. So how does he describe a family physician? So this is always in the most important portion of his book. This is the first few chapters of his book, because everything else tries to illustrate this. Okay, so what does he say? Well, the family physician is committed to or is taking care of the person rather than the particular disease or the body of knowledge about the disease or the organ system. He's committed to the person. Is taking care of the person. The family physician tries to understand the disease in its context. It's not just the disease and what's happening to the organ and the chemicals and whatnot, so that you can come up with a drug that deals with the organ. No, he's trying to understand the context. How is the patient reacting to it? How about the family? How about the community? How about the group of people experiencing the same disease? So there's context, there's environment, there's social context, right? So you won't see, as far as he's concerned, you shouldn't be seeing someone who sits down and says, well, the latest research and randomized clinical trial and the guidelines from our experts says that this new drug is better than the old drug by about 20%. I have to give it to you. And the patient comes back and doesn't take the medication. And then you say, you should, right? You need it, but doesn't ask why. And the reason why the patient is not taking it is because he cannot afford it. He can afford the older one, which actually works, but he cannot afford the new one. Now, the provider should have at least asked about whether he can actually do it. An RCT about the drug being effective is only helpful if you can actually swallow the drug in the same way that participants in the clinical trial did. That means you're swallowing it every day. Of course, the ones in the trial didn't have to buy the medication. Now, if you buy the medication and then sacrifice what you're eating, that's even worse. So the context is very individual, and in his mind, you don't just throw out the context, right? How is the family reacting to it? How's the community? Okay, so you look at the context. Now, if you broaden your perspective and start looking at the context, then automatically you will see other problems and other things you have to take care of so that you can take care of the patient better. Okay, so the context is important as far as he's concerned. Now, the family physician also tries his best to prevent the patient from getting sick, to keep his patients healthy. So that means he doesn't wait for the patient to get sick and then go to his clinic, or he doesn't make the patient feel like they don't need to go to his clinic unless they're really sick, right? So that's lifestyle management and prevention of disease. And as far as Dr. Mcwhinney is concerned, that's the doctor's main job, not acute treatment of something that already happened. His job is to keep, as much as possible, keep all his patients healthy, right? So it's preventive, okay? And as far as mental health is concerned, you also don't wait for the patient to end up with a pathological mental health problem. You address the brewing relational or personal problem before it gets worse and worse and starts causing more complicated problems, right? the family physician as far as he's concerned. Remember, this is like 1940s, working in his father's clinic inside the community, going to homes. So as far as he's concerned, the family physician should be inside the community, because if you take the family physician out of the community, a lot of things get taken away, and he thinks those things are very, very important. Now, being a part of the community and having this broad perspective and context, he also feels like the family doctor should also be integrated with the people who are doing social services. Now, obviously, nowadays, there's no integration between mental health and social services and general practice, right, and primary care. I mean, he wanted it to be well integrated several decades ago, but the gatekeeper doesn't need that kind of integration. He's actually very narrow and focused nowadays, right? Now, living in the community is becoming less and less common, especially if the patients are moving out of the community and going into urban areas. That's also the reason why the rural community general practitioners, family med doctors, and the community doctors started questioning the gatekeeper, metropolitan area, urban-looking generalist practitioner and family med doctor. They feel like that's not what we were after. We talked about this and we're supposed to be going in this direction. How come you ended up there? Right? So that's the problem. It's becoming a bigger problem. And unless it drastically shifts its course, and I don't think it will, because it's already too addicted and flushed with money, or unless something happens, like it becomes socialized, which introduces a whole bunch of problem and doesn't really fix the situation if not done well, I don't think it will change. So what will probably happen is you'll probably have a separate field going in the direction that was originally planned. They can probably call themselves community practice or public care or public health medicine. Now, of course, they have to make sure that everyone knows what public health field is and the clinical public health field is. You have to fix the details, but what will probably happen if it gets worse and worse would be a separate clinical field composed of doctors working in the community. Now, later on, of course, the knowledge base of that field will be brought into the urban centers. Okay, so anyway, that's not the topic for now. Now, he also says the family doctor visits the patient in their homes. Why say that? Well, because that's what his father did, and that was what he was doing before he went to Canada. They were seeing the patient in their homes. And again, as far as he's concerned, just like living in the same habitat as his patients and families, going into their houses introduces very, very important knowledge. Going into the houses also helps a lot with the care of the patient. So you go into the house, it's very personal. It's an open communication. Of course, the person who enters the house regularly becomes part of the family in some way, right? So you become part of the family. You can take care of their relational issues if they need help, their psychosocial issues, and you get to know each member of the household who are your patients. You get to see them more and more as people, and you can keep them healthy. You can take care of their needs, not just the disease needs, but also the psychosocial needs better, right? And so it follows that he thinks that the family physician pays attention to the psychosocial needs. And later on, he was actually, Dr. Mcwhinney was actually writing already about spiritual needs later on in his life, like late 1980s and 1990s, and that kind of completes it, the whole person. And we should be paying attention to that. Obviously, right now, we know what general practice gatekeeper managed care looks like, and it's not there, right? In some developing countries, they still keep at it. They mouth out the elements of the 1980s textbook and talk about family and some basic chapters in family therapy, but they talk about family therapy as if it's another skill, and they don't see why it was brought in. It's not as if somebody says, let's create another field and let's create a doctor who knows family therapy. That's not how it worked. Or let's create a doctor who knows family therapy plus community work, or plus social work, or plus public health. That's really not how it works. It's more like, this is a family physician and we need to give him more tools. So what can we give him based on our idea of who he is or who she is? Okay, these are the things he needs. That's pretty much how those things got brought in. Okay, and then finally, of course, you live in the community and you see the context, you see the family, and you see everyone else, your other patients who are also living in the same community you're living in. And so you have a good idea what the resources are, the people to tap, the groups to tap, the church group, the school, the social support group, the medical resources and the healthcare resources of that community, access to the distant hospital, you have a good idea of what gives, right? So in a sense, you're helping out the family prioritize the resources, the very limited resources. And that's the idea of managing resources. Okay, so if you look at it that way, then everything will make sense. All these things that a family physician should be doing. Again, it's not like, a family doctor needs to have managerial skills. So, let's go to the management courses and then teach them some management stuff. Those are the tools, but that's not the idea. That's not the core idea. The core idea is just there. You're looking at the resources and you're taking care of these people. So maybe you should have some kind of very applicable, not the management thing they do in corporations, very applicable community resource management stuff. And obviously, it's not, management doesn't mean you know where to refer. Like, that's just, the specialist network is just a small part of being a helper in the managing of resources, who's also aware of the limited resources in the community. So guide them in accessing the available resources of the community. That's different, right? So you don't just, let's pick this management course and then let's pick this counseling course and then maybe a little bit of public health kind of workshop that came from this one, and then that we'll call it a day. That was the GP of the 1930s approach. You rotate every 2 weeks to 6 weeks in different departments and you learn different stuff, and then you go out with little bits of and pieces of everything. And definitely that's not the idea in Dr. Mcwhinney's head. So that was pretty much the thought process, or that's pretty much what family practice was, or what they think family practice should be during the 1980s and the 1990s. Of course, obviously it didn't turn out that way, but that was the idea a few decades ago. Now, that's also the reason why different groups came up with different illustrations. Like, this actually made the problem worse rather than better. So, because he was describing different things the doctor does, so they came up with like different hats. So he's a manager, he's a researcher, he's a clinician, like an internist or something. So he's like a family counselor or individual counselor. So they have an illustration of the different hats of a family physician. Or some would go for a star, like the 5-pointed star or the hexagram, the 6-pointed star. And these are the different roles. Now, the problem with that is you make the role appear separate, like, they're not related to each other. But the original idea is, this is one person, this is the idea of a family physician, and this is what he does. Okay, so when you separate the roles, then it's so tempting and easy for someone to say, well, I like the 3 points of the star, and I'm not really into the management, or I'm not really into the counseling stuff. So those are little tiny points. Well, I like these 3 hats, and then maybe I can turn this other hat into a small hat. That's not the way it should be, right? So just be careful.